Joanne Duffy's Quality Caring Model by Caitlin Rice. Joanne R. Duffy is the theorist and RN who developed the Quality Caring Model. She completed nursing school at St. Joseph's Hospital School of Nursing in Providence, Rhode Island, and completed her BSN at Salve Regina in Newport. Her master's and doctoral degrees were completed at Catholic University of America in Washington, D.C. Her vast career includes clinical, administrative, and academic roles. She directed 4 graduate nursing programs including critical care, care management, nursing administration, and a PhD program. She is a former division director of the School of Nursing. She has taught nursing theory, research, and leadership in PhD, DNP, master's, and honors programs. She held clinical positions in intensive care, coronary care, and emergency services, and is a cardiovascular clinical nurse specialist. Currently, Joanne R. Duffy is the West Virginia University Hospital's endowed professor of research and evidence-based practice. She is also the interim associate dean for research and PhD education at the Robert C. Byrd Health Sciences Center and an adjunct professor at the Indiana University School of Nursing. Joanne Duffy has made vast contributions to the nursing profession. She was the first to examine the link between nurse caring behaviors and patient outcomes and developed the caring assessment tool, otherwise known as ECAP. She developed the middle range quality caring model to guide professional practice and research and expose the value of the nursing profession. She was the principal investigator on the National Demonstration Project, Relationship-Centered Caring in Acute Care. She was also the principal investigator for 2 caring-based intervention studies. Joanne was the consultant to the American Nurses Association in the development and implementation of the National Database of Nursing Quality Indicators. Joanne Duffy authored books focused on the caring relationships as the central organizing principle of health systems. The first edition of her book, Quality Caring in Nursing: Applying Theory to Clinical Practice, Education, and Research, received the AJN Book of the Year award in 2009. Overview of the theory behind the quality caring model. The model was originally developed in 2003 by Joanne Duffy to guide nursing practice and research. The idea for the model was first developed in the late 1980s as hospitalized patients frequently described a dissatisfaction with care and stated that it seemed that nurses simply did not care. This motivated Duffy to develop a tool to measure caring and study the link between nurse caring and health outcomes. Few theories were available to guide the development of caring based on nursing interventions and the relationship between nurse caring and quality care. Dr. Duffy and Dr. Hoskin developed the model, with caring relationships being the core concept of the study. Caring relationships were thought to be part of the daily work of nurses. However, nursing relationships are different than the caring between families and friends, because professional nurse caring requires specialized knowledge, attitudes, and behaviors that are directed toward health and healing. These positive attitudes and behaviors resulted in feeling cared for and was a positive emotion necessary for taking risks, feeling safe, learning new healthy behaviors, and participating effectively in decision making based on evidence. The sense of feeling cared for was considered necessary for improved nurse-sensitive outcomes such as knowledge, safety, comfort, confidence, engagement, and positive experiences of care. This model was considered supportive to professional nursing because nurses themselves were theorized to benefit. The model supported professional values and contributed to meaningful work. The purpose of the original quality caring model was to guide professional practice, describe the conceptual, theoretical, empirical linkages between quality of care and human caring, and propose a research agenda that would provide evidence of the value of nursing. The model was revised 2 times since the original in 2003 due to modern society, advancing health systems, and the individuals who work in it. The revised model is considered a middle-range theory because it draws from other works, is practical, and can be tested. The model challenges nurses to use caring relationships as the basis for daily nursing practice. Quality is a dynamic, nonlinear characteristic that is influenced by caring relationships. Positive human connections are formed that influence future interactions and intermediate health outcomes. Caring is a process that involves a reciprocal relationship between human persons where the positive emotion of feeling cared for is attained. Feeling cared for enables the conditions for self-advancing systems and over time will enhance an individual or system's well-being. The emotion of feeling cared for is a performance indicator for quality nursing care. Caring relationships enhance interprofessional practice and are theorized to benefit nurses themselves by maintaining professional values and contributing to meaningful work. Quality is a characteristic that is influenced by caring relationships. It is the goal of the nurse to use ever-advancing skills and knowledge to develop positive caring relationships with patients and families and influence positive health outcomes. Joanne Duffy stated, "Quality is not an endpoint per se, but a process of continuous learning and improvement that treats patients as full partners and is fully integrated into the work of health professionals." The following graphic displays the quality caring model. The model begins with humans in a relationship. The relationship may be with oneself, others, or a community. The nurse enters relationship-centered professional encounters with the focus being caring behaviors to promote the emotion of feeling cared for. The professional encounters may be with a patient, families, health professionals, or health systems. The resulting emotion of feeling cared for leads to positive intermediate health outcomes and influences future interactions that enable the conditions for self-advancing systems and enhanced well-being. The four main concepts in the quality caring model include humans in relationship, relationship-centered professional encounters, feeling cared for, and self-advancing systems. Humans are unique beings with various characteristics. Recognizing the differences in human beings leads to individualized nursing interventions. Humans are also social beings who are connected to others through birth, family, work, play, learning, worship, and communities. These interactions allow humans to mature and advance. When relationships are of a caring nature, the emotion of feeling cared for is generated. This is a positive emotion that prompts individuals and systems to change, develop, and self-advance. This leads to quality health outcomes. Caring relationships from healthcare workers enables patients to focus on their health, learn, change lifestyle habits, follow recommendations, and participate in their own healthcare decisions. Patients report feeling understood and more confident in their ability to make progress over time and in their overall well-being. Self-advancing systems are considered natural self-caring or self-healing. In the quality caring model, the overall role of the nurse is to engage in caring relationships with patients, families, healthcare workers, and the community to produce the feeling of feeling cared for. These actions will positively influence patient health outcomes. Specific responsibilities of the role of the nurse include initiate and sustain caring relationships with patients, families, other nurses, and all members of the healthcare team, maintain awareness of the patient-family point of view, maintain self-caring activities including personal and professional development, integrate caring relationships with evidence-based nursing interventions to promote positive health outcomes, maintain an open and flexible approach, use measures of caring to evaluate nursing care, and attain and advance knowledge and expertise in caring processes. The following are the four relationships necessary for quality caring. They include self, community, patient and family, and the healthcare team. Inner awareness and self-care is required to adequately care for others and to have an authentic interaction. One must know themselves to know others. Short breaks or pauses to care for self allows nurses to refocus on the caring nature of nursing. Reflective awareness allows nurses to know what they are doing right and provide learning opportunities. Initiating, developing, and sustaining caring relationships with patients and families is a nursing-specific role that involves intention, choice, specific knowledge and skills, and time. A professional nurse makes the conscious decision to care for another and develop a caring relationship. Collaborative relationships with other members of the healthcare team are essential for quality healthcare. Lastly, engaging in communities outside of the family allows one to connect and enhance the lives of each other. These relationships enhance the vitality of the community and enrich the lives of the nurse. The following are caring factors thought to be necessary for human caring in the patient-nurse relationship. They identify specific cognitive and behavioral characteristics necessary for caring relationships. Clinical caring requires knowledge and skills combined with caring values. The first is mutual problem solving, where mutual discussions engaging patients and families regarding their health problems. Attentive reassurance assures patients and their families that they can rely on nursing and a sense of security develops. Human respect appreciate the patient's integrity, celebrate and talk about the patient's life, ensure the patient's honor is maintained. Encouraging manner the demeanor or attitude of the nurse, verbal and nonverbal messages, including body language. Appreciation of unique meanings, knowing what is important to patients associated with their life experiences. Healing environment, maintaining privacy, safety, and control, the ability to ask questions and learn from mistakes in a non-punitive manner. Basic human needs includes physical needs, safety and security needs, social and relational needs, self-esteem needs, and self-actualization. The human body is the most intimate part of the self that deserves caring and attention and respect. And lastly, affiliation needs. Responding to the patients and their families, allowing families to be engaged in the situation and including them in decision making. Strengths and weaknesses of the quality caring model. Strengths include patient-centered care where humans are complex individuals, a focus on collaboration with all members of the healthcare team, a focus on self-care of the nurse, including emotional, educational, and well-being. Results of the model improves patient views of care and health outcomes. The model can be tested and used in research to demonstrate the impact of the nursing profession separate from other health professions. Promotes continuous knowledge and skill development of the nurse. Includes building relationships with community groups as well as professional groups. Some of the weaknesses noted were nurses often have limited time to spend with patients and develop caring relationships that can continue over long periods of time. And this model may not be applicable in nursing settings such as the emergency room and ICU, where time with patients is limited or patients are not conscious. In this case study, the patient is a 28-year-old female who is 5 days postpartum after delivering a preterm infant 28 weeks gestation due to premature rupture of membranes. The infant required CPAP for respiratory support and nutritional support through an NG tube. The infant had frequent oxygen and heart rate decreases that required stimulation and intervention. After being stabilized, the infant was transferred from a different hospital due to a high census. The mother is Spanish-speaking only and upset that the infant was transferred to a different hospital. The mother frequently cries at the bedside and wants the infant transferred back to the original hospital because she is concerned that the current team cannot successfully care for the infant. The nurse begins by sitting with the mother and using a Spanish interpreter to communicate effectively. The nurse smiles and uses a gentle, calm voice whenever she speaks to the parents or infant. The nurse maintains eye contact and uses appropriate body language. These actions promote a healing environment and trust. The nurse explains the plan of care for the infant and discusses the desires of the mother. The nurse uses her vast clinical knowledge of premature babies to explain the infant's condition. The mother wishes to be included in the plan of care for the infant and wishes to actively participate in the baby's care. The nurse takes this knowledge and applies it to her daily routine. The nurse encourages the mother to bathe and change diapers. The mother completes skin-to-skin care and holds syringe feeds while they go into the NG tube. The nurse encourages these behaviors and encourages the mother to increasingly participate in care to further independence. The nurse communicates with other members of the healthcare team during daily rounds and includes the mother with a translator. The nurse communicates with social work to ensure that the mother is emotionally cared for and receives any counseling she may need. All members of the healthcare team meet with the mother once a week with an in-person translator to discuss the status of the baby and any concerns the parents may have. This demonstrates team collaboration and a caring relationship between healthcare workers. The nurse's actions promoted the emotion of being cared for and allowed the mother to become actively involved in the plan of care. The continued acts of caring from the nurse and other team members over several weeks lead to self-advancing systems where the mother could independently care for the infant. The mother reported the care that she and her son received as high quality, and she displayed the positive emotions of feeling cared for.